Hi, this lecture is going to be about the most common pediatric or orthopedic manifestations in infants and newborn. In this lecture, we're going to speak about the three most common things that the orthopedic or the pediatric orthopedic will be consulted for in the infants and newborn, which is the hip dysplasia, the clubfoot, and the Erb's palsy. In the hip dysplasia, we're going to speak about the pathology of the hip dysplasia, the risk factor, and the treatment algorithm. In the clubfoot, we're going to speak about the pathology, the clinical presentation, and the treatment options. In the Erb's palsy, we're going to speak about what are the risks for Erb's palsy and other obstetric brachial plexus palsy, and we're going to speak about the clinical presentation and the differential diagnosis and the prognosis of this condition. A good source that you can use is this book written by myself, Dr. Naga and Dr. Abdu, which is the second edition of the first book, The Pediatric Orthopedic, and now it's Pediatric Orthopedic and Sport Medicine. Also, I would like you, if you want to have more information about these topics, to go to their individual lecture. I have a lecture for dysplasia, I have a lecture for Erb's palsy, and I have a one for clubfoot, and also I have a lecture for the two tests for hip instability, and I'm going to include a link for these lectures in the comment section. So if you want more detail about this topic, you can go to these previous lectures. So let's now speak about the common musculoskeletal manifestation that you can see in the newborn. As we said, we picked three topics: DDH, Erb's palsy, and clubfoot. So let's start with the DDH, or the hip dysplasia. Hip dysplasia is a spectrum of disease. Okay, so this is the normal hip, normal adult hip. It has a femoral head and it has the acetabulum, and you see the femoral head is deep in the acetabulum, or what we call the socket. So the dysplasia is a spectrum of disease, anything from just like a shallow acetabulum to completely dislocated hip. So all this is called hip dysplasia. So what are the risk factor for hip dysplasia? When do you suspect, oh, this patient has a higher chance of having hip dysplasia? It's FFF, female, firstborn, and family history. So it's more common in firstborn, female, and in family history. And it has been associated with breech presentation. Okay, so it has been found that the risk factor associated with dysplasia is breech presentation, especially in the third trimester. So of course, breech birth is important, but more important is breech presentation in the third trimester. So FFF, firstborn, female, family history, and breech presentation in the third trimester. So the incidence of hip dysplasia, it's about 1%. So the hip dysplasia is about 1% of birth, and the frank dislocation, the complete dislocation, is about 1 in 1,000. Left hip is affected more than the right hip, and it can also be associated with other anomalies that associated with tight intrauterine space, like metatarsus adductus or torticollis. So these, if you have a patient with metatarsus adductus or torticollis, think about a hip dysplasia, because these three can be associated with tight intrauterine space. So let's review how to assess the hip stability in newborns. Remember that hip dysplasia is completely asymptomatic, so there will not be any symptom. You will have to look for it, or what we will describe later as the surveillance. So you will have to assess the hip stability. There are two main tests for assessment of hip stability: Barlow test and Ortolani test, and we're going to go in details in both of them. So among these two, Ortolani test is by far the most important test, and it assesses if the hip is dislocated or not. So the Ortolani test is a test to see if the kid's hip or the newborn hip is out of the place and you can reduce it. So it is to assess if the hip is dislocated by assessing the reduction. So here this is two pictures from my book. You can see here we're starting here with the hip dislocated. So here is the proximal femur, it's outside the socket, and then what you're going to do is you're going to abduct, like move the leg outward, and we're going to describe the how to do the test in detail, and then you push the femur from posterior to anterior, and if there is a clunk, which basically means like a change in the position, this you will feel this clunk, and this will be a positive test, which is basically the hip moving from being out to being in the socket. So the Ortolani test, you start with the hip adducted, you go into abduction. The knee here is in the palm of the hand, the thumb is on the medial side, the other four fingers are on the outer side, and then you move, you hold both in the same time, and you do one by the one side but at a time. You abduct, you move the hip, you move the whole leg outward, and then with these fingers you're pushing, making this anterior push from posterior to anterior, this direction, to reduce the hip and feel the clunk. Knee is in the palm, thumb in the medial side, other fingers on the lateral side. Abduct, move the whole, you're holding both at the same time, doing one side at a time. You move the whole leg outside, which is called abduction, and with these fingers you're pushing from here, trying to reduce the hip and feeling this clunk. Here is a video of the test. This video, as I said before, is present in a separate lecture in my channel, and you can see again the thumb here, the thumb on the medial side, on both sides. You're holding both sides, doing one side at a time. The fingers, the outer four fingers are on the lateral side, and the knee is in the palm of the examiner, and you abduct, you move the whole hip out, and you with these fingers you're pushing from posterior to anterior, and you can see the clunk. This is an indication that the hip is reducing. Of note, this is a neuromuscular case, so this kid is slightly older. Remember that in most kids the Ortolani test will become negative even in dislocated hip after about 4 to 6 months, because the hip now becomes more stiff in the outside position. So reduction of it may not be easy while the child is awake. Let's see the video again. You can see here the knee is in the palm of the examiner, both sides hold in the same time. You move abduction, and then with these fingers you're pushing anterior when you abduct to try to reduce the hip in position and feel this clunk. Now this is another test, same thing. This is a normal kid, not neuromuscular. See the same thing here, knee is in the palm, the thumb is on the medial side, other fingers are on the outer side, and the examiner, so if you see, we're starting, if we go early here, we started first with in the adducted position with the Barlow, and then you abduct now and doing the Ortolani test. And you can see here the clunk, you can see the change in the position. Yes, you can see it here. So with the abduction and with the finger pushing the bone or the greater trochanter from posterior to anterior, you can reduce the hip and feel the clunk. Click is not important. Click has basically very limited to no clinical importance. You can see the clunk here. The clunk is something you feel it. It's with the hip going from outside to in or from inside to out, feeling this motion here and feeling the change of position. This is the clunk. Now, after we talked about Ortolani, let's talk about the Barlow test. As we said earlier, Ortolani test is much more important than the Barlow test. The Ortolani test, the previous test, is to see if the hip is out. The Barlow test, on the other hand, it is to assess if the hip joint is subluxable or not, meaning is this hip is unstable and I can push it out of the socket or not. As we're going to see when we go to the recommendation, the value of the Barlow test is not as important as the Ortolani test. And recently, in the most recent recommendation for the American Academy of Pediatrics, it actually changed the value of positive Barlow test. And we're going to see all this when we come to the recommendation. So the Barlow test is, as we said, is to see if the hip is subluxable, meaning the hip is in and you can push it out. So you start with the hip in abduction, you bring the hip in adduction, meaning bringing the hip inward, and you push backwards. You want to see if you can get this hip from being inside the socket to outside the socket. So if that happened, that's called Barlow positive, meaning that the hip is not stable and it can be pushed out of the socket. So Barlow test, you're bringing the hip from, you're bringing the leg from outside inward, meaning adduction, adduction, but to make it obvious in the pronunciation, we say adduction, and you push backwards, and if it's positive, the hip will come out of place and you will feel the clunk. So let's now go to the Barlow test. The Barlow test has the same position as the Ortolani test. So the knee is in the palm, the thumb is on the medial side, the outer fingers are on the outer, on the lateral aspect of the thigh, and you adduct, bringing the leg inward, and you push backwards, and you can see the obvious here clunk. So here it is, you brought the leg inwards, called adduction. To make it easier for the listener, I will say adduction. And you notice previously I said abduction when we were talking about the Ortolani. This is just only to make it easier for the listener to the difference between adduction and abduction. So here we adduct here, bring it inward, and we push backwards, as you can see, and you will feel the clunk. So the Barlow test here, so you're bringing the hip bringing the leg to the medial side, which is called adduction, and then you're pushing backwards, as you can see here, and you will feel the clunk if it's positive. So now, just to summarize, I want you to look to the Barlow and Ortolani test as like a spectrum of movement. So the kid is supine. You're holding the leg. You're holding the leg in your palm. So remember, these are newborns, so their leg is very small. So the knee is in your palm. The thumb is on the medial side. These are the other four fingers are on the lateral aspect. Same, so you have the same holding in both the Barlow and Ortolani. In the Ortolani, as we said, this is the most important one, and recently in the new recommendation, as we're going to talk later, in the 2016 recommendation, which differs from the 2000, the Ortolani test became the one that is we really take into consideration. The Barlow test, the new recommendation is not to depend on it. There is even some recommendation not to do it. However, we will still discuss both, and we will discuss the new recommendations. So as you see, it's the same position, same holding of the knee. It's in the palm. The knee is in the palm. Thumb is on the medial side. The other four fingers are on the outer side, and then you abduct, which is abduct, but I'd like to pronounce it in a way that it's easier for you to appreciate. So you abduct, bringing it out, and use this finger to push the hip. And if you felt the clunk, that means that this is a positive. Remember, clicking is not something that we're looking for. It's a normal finding. And the Barlow test, you will bring the leg inward and you will push backwards. And then if it comes out, that's positive, and both of them requires clunk. And again, so it's the same position, supine, knee in the palm, thumb on the medial side, the fingers are on the other fingers on the outer side, and you do abduct and pressure from posterior anterior to see if you can reduce a dislocated hip. That's called ortolani. Or you adduct and you push backward to see if the hip is subluxable. You can get it out of the socket, and this is the Barlow test. So Barlow to see if the hip is subluxable, and ortolani is to see if the head is dislocated. Ortolani is the more important test. Barlow test, especially with the new recommendation, is not as important. So ortolani to see the dislocated hip, if you can reduce it. Barlow to see if the hip is subluxable and you can get it out of the socket. So as we have discussed, hip dysplasia is completely asymptomatic. There is no signs that you can see. You have to do tests. You have to do the surveillance, as we said, and as we're going to discuss in details. And also you may have to use imaging. Imaging in newborn up to the age of 4 months and sometimes up to the age of 6 months is by musculoskeletal ultrasound, doing the hip ultrasound, and it's called dynamic ultrasound. Why? Because you assess the hip in different position. We're not going to go too much into the details of the ultrasound and the angles. You can, if you want, go back to the lecture, the specified lecture for the ultrasound, for the hip dysplasia, and it will have lots of the description of the angles. I'm going to go through them very quickly here so that I can give you an idea when you see the report. However, if you want more information, go back to the lecture of the hip dysplasia. So here is, as you can see, the transducer will be on the outer side of the hip, and if you look to this x-ray of the hip, you may can reflect that into this picture for the ultrasound. So this is the femoral head, this is the iliac crest, this is the acetabulum, this is the triradiate cartilage, which is this area here, and these are the muscles, and then this is the alpha angle, and the alpha angle should be ideally above 60, and this is the beta angle, which basically represent the cartilaginous. So alpha angle is bony. You want the bone to be deep, so you want to have a big alpha angle, and the cartilaginous, you don't want the cartilaginous part to be big, so you want a small beta angle. So if you see the hip, the hip here, the femoral head is deep in the acetabulum. If it started to go out like this, you will push the cartilage, and the beta angle will be large, and the alpha angle will be smaller if it's more shallow. So you want the alpha angle to be large, more than 60. You want the beta angle to be small, less than 55. So here is the example. Here is this here, muscles, the femoral head. You can easily see it. It has the dot, and then the iliac crest is here. So when you draw a line from the iliac crest, so this is a line that I put here. This is not the normal line. Here is the iliac. If you draw a line from here, most of the hip is inside the acetabulum. That means that the hip is in. You can see here is the alpha angle. So this is from the triradiate cartilage to the edge of the acetabulum, and it's more than 60. The beta is small. If you imagine the hip will go this way, coming out, or subluxation, it will get the beta large. So you don't want a large beta. You want a big alpha angle, because that tells you that the hip is deep. If the hip is like this, if the acetabulum, is like this, that means it's shallow and the hip is out. But if the acetabulum is deep, that means that the femoral head is inside the acetabulum. It's deep inside the acetabulum. Another example here showing that the femoral head started to go out from the socket. So if you see here, the acetabulum is shallow, the alpha angle is small, and then the hip is out, so it pushed on the cartilaginous, and the beta angle is large. Remember, big BBB, big beta bad. You don't want a big beta angle, you want a smaller beta angle. and here the hip became completely out. Again, this line here is not part of the ultrasound. This is, I drew this line to show you an extension of the iliac crest. You can see the acetabulum is very shallow. If you draw the line here and the beta is too big, the femoral head is pushing it out. So you see here, this is a very shallow acetabulum, very large beta angle. This hip is completely outside the socket, so this is dislocated. Here you can see another example here. One of my patients, here's the muscles. The hip is outside the acetabulum completely. The acetabulum is empty. The head is outside the acetabulum. This is the same patient. That's why we call it dynamic ultrasound. So here is the ilium. This is the extension of the ilium. You can see the alpha is very small here. The beta is very large. The hip is all outside the acetabulum. However, when you abduct, it comes partially back. So that's why we call it dynamic ultrasound, because you assess the position of the hip in different. You assess the position of the hip in different different positions of the leg or the lower extremity. So the examiner will abduct the lower extremity and will see if the hip goes inside the acetabulum or not. So now in the beginning we talked about surveillance by the Barlow and Ortolani, and now we're talking about the imaging. The imaging in the first 4 months is by the dynamic ultrasound to see the hip and to see the acetabulum and to see the development of the bony acetabulum, to see the cartilaginous acetabulum, all this by the dynamic ultrasound. So let's speak now about the recommendation for the American Academy of Pediatrician, the AAP, regarding the hip dysplasia. So as I told you, the concept of surveillance, very important, the concept of surveillance, meaning that you have to look for the DDH. It's not something that will show up itself, like as we're going to see maybe in the Clubfoot or in the Erb's palsy. The kid is so obvious that he has a problem. Hip dysplasia is completely different. You have to look for it. So that's called surveillance. You have to look to see if there is dysplasia or not. And you will do this by assessing the hip stability in every visit till the walking age. And possibly, as we said, using imaging, as we said, the hip ultrasound, dynamic ultrasound for the first 4 to 6 months. After that, the normal X-ray or radiographs. So the concept of surveillance, meaning that you will look for it in every single visit until the age of the walking age, and possibly need imaging, which will be either hip ultrasound in the first 4 to 6 months or radiographs. There is new recommendation that came in 2016. So those of you who saw the video for the hip dysplasia before, the following recommendation is slightly different than the one in the video, because the one in the video was based on the recommendation of the 2000. There is new recommendation 2016 that we're going to discuss and mention the difference between them and the one that used to be before in 2000. Again, every newborn should be screened by the physical exam. The screening is by mainly the Ortolani. That's one of the difference. So the Barlow test is not does not have the same weight as it used to have before, because studies shows that most patients with Barlow, either immediately at birth or in the 2 weeks, they're going to clear by 4 weeks. If they don't clear by 4 weeks, now you can start the process of the referral. But the screening is mainly by the Ortolani. Remember, Ortolani starts with O. It means that the hip is out. Start with O. O for Ortolani means the hip is out by O. So O for O, Ortolani for out. So that's why the Ortolani is more important, and in the 2016 it is the one that the recommendation based on for the referral. Also, the 2016 say that routine ultrasound for all newborn is not recommended. So 2 things in the surveillance: don't get ultrasound for every single kid, that's not recommended, and do the physical exam, which is basically the Ortolani test in every kid. You still can do also the Barlow, and the recommendation does not recommend against it, but it in the same time it does not carry the same weight. So surveillance by Ortolani and Barlow, mainly Ortolani, O for out, Ortolani for out, O for O, O for Ortolani, out, O for out. So every kid will be screened, and then ultrasound. Do not do routine ultrasound for every single child. So if the test is the Ortolani test is positive, and we said the Ortolani is the more important one, and positive means a clunk, not a click. So if you have a clunk when you do the Ortolani test, I told you Ortolani starts with O and out start with O. That means the hip is out, and what you do is orthopedic referral. You do not need to get ultrasound. You don't need to get an X-ray. If you have positive Ortolani, orthopedic referral. You don't have to confirm. There is no need for ultrasound, just orthopedic referral. So if you do the Ortolani and you have a clunk, it's orthopedic referral. On the other hand, the Barlow test, so if you do the Barlow and it gives you positive result, the recommendation is to repeat it. So if this at the newborn, repeat it at the age of 2, and then if it still persists, repeat it at the age of 4, and if it still persists, that's the time when you refer. So the new recommendation tell you referral for orthopedic at the positive. If you have positive, mean clunk, Ortolani. If you have Barlow, most studies show it will spontaneously improve by the age of 4 weeks. So if you have it at the age of newborn, you can repeat it again at the age of 2 weeks. If it's still positive, you can repeat it at the age of 4. And now if it's positive, you can refer. If you get an equivocal result, basically means that there is like a soft click, it's not a clunk, or if you have an asymmetry between the two hips, you can repeat the exam after 2 weeks. So if you do the exam and you feel some limitation in the range of motion, you don't have like a firm clunk, but you feel that one hip is different than the other, repeat the test after 2 weeks and see if that persists or not. Ortolani, referral, no need for imaging studies. Barlow, if it's positive, you can repeat it. And if it persists, that's when you refer. Also equivocal, like asymmetry between the two hips or soft click, repeat the exam after 2 weeks. So now let's go again to the recommendation regarding imaging. The imaging is ultrasonography, what we said, dynamic ultrasound till the age of 4 months, and X-ray starting from the age of 6 months. Also very important, don't try to get ultrasonography before 6 weeks, because it can have lots of false positives that will confuse you, will result in orthopedic referral for kids that don't need it really. So ultrasound, if you plan to get ultrasound, wait till the age of 6 weeks. What are the indications if there is a risk factor? The most important risk factor is breech presentation in the 3rd trimester. As we said, we mentioned that before in the in the second slide about DDH, that breech presentation in the 3rd trimester is a risk factor. Whether or not the patient was delivered C-section or vaginal, what you're looking for is the breech presentation. Also, if there is positive family history. If there is an inconclusive physical exam or previous instability, you can refer. So if the patient had positive Barlow that improved, however, you're still worried, you can get an ultrasound. If you notice that maybe there is difference in the hip exam, right and left, there is difference in the range of motion, also you can refer. If there is parental concerns, the family are worried, you can always refer for ultrasound. Or if there is a history of improper swaddling, meaning that the family did swaddling for the patient in adduction and extension, that's an important risk factor. If you discover that the family did this, that's an indication for ultrasound. And also you can basically send all patients with breech delivery for ultrasound. However, as we said, what is important is breech presentation in the 3rd trimester. That's the major risk factor. So here it is from the recommendation of the American Academy in 2016 that has been confirmed in 2021, and discuss about the imaging. So in the imaging, as we said, it's dynamic ultrasound till the age of 4 months. Do not do it before 6 weeks, or radiographs at the age of 6 months. When is to do this? If there is a breech presentation in the third trimester, as we said, regardless of vaginal or cesarean delivery. If there is a positive family history, these two are very important risk factor. If there is a previous of history of a clinical instability, mean that you detected a Barlow test that improved, or there was like asymmetrical exam, and you want to make sure that the patient does not have a dislocation. If the family are concerned, or if there is an improper swaddling, or as we said, if the physical exam is not very conclusive. So if it's, of course, if it's conclusive, the indication is to do orthopedic referral. But if it's suspicious or inconclusive, and this is where you get the imaging study. So after we talked about the imaging studies and the recommendation of the 2016 American Academy, let's talk about the indication for referral and the recommendation in the 2016 publication of the American Academy of Pediatrics. Most important thing is positive ortolani, and we talked about ortolani starts with O, same as out. So if you have positive ortolani, that means the hip is out and you need referral. You don't need imaging study. You just need to refer this patient for treatment. Also, if you have an infant older than 4 weeks of age, so after 4 weeks you're examining the child and you find one hip has limited abduction compared to the other, or both are having some limitation in the hip abduction, that's an indication for orthopedic referral. There is relative indication, so these are the two most strong indication, the ortolani positive or limited hip abduction. The relative indication, if you have a patients with risk factor for DDH, as we said, a patient has a breech presentation in the third trimester, or if you have a questionable examination, Barlow positive. Remember, this is different than in 2000 recommendation. In 2000 recommendation, Barlow positive was an indication for referral. But now, as we said, if you have a Barlow positive, it is recommended that you repeat it at the age of 2 weeks. So if it's positive at the newborn, you can repeat it at the age of 2 weeks. And if it's still positive, you can repeat it at the age of 1 month. If it continues to be very positive, that's an indication for referral. Because we know most of the Barlow positive will spontaneously correct in the first 4 weeks of age. So if it does not correct, that's an indication for orthopedic referral. Or if you have an asymmetrical gluteal fold, that sometimes is an indication of dislocation. Not every asymmetry in the gluteal fold or the thigh crease, because that can be a normal finding. But if you have that and it persists, there's also an indication for orthopedic referral. Or if in general the recommendation left it open, so if the pediatrician is worried or the family is worried, you can refer for orthopedic referral. So ortolani positive, limited hip abduction, that's an indication. Other relative indication, if there is a high risk factor, especially breech presentation in the third trimester, if the Barlow positive does not improve, and we said this is different than 2000, because in 2000 Barlow positive by itself, if you've noticed one time, that's an indication for referral. Now Barlow positive is mainly a thing that you just need to follow the patient and you don't need to refer. However, if it persists, or if the pediatrician is worried, they definitely can refer a Barlow positive patient, or if it persists beyond 4 weeks. Or if there's asymmetrical gluteal or thigh creases, also that's an indication for referral. So what is the treatment? We said there are indications for orthopedic referral for newborns and kids up to 6 months. The treatment is Pavlik harness. This is the Pavlik harness. The Pavlik harness, what is the concept behind it? The concept behind it is you want to prevent adduction and keep the legs slightly abducted. As we said before, abducted means to the outside. So if you see here, both thighs are abducted. And to maintain slight flexion, this flexion is between 90 degree to 100 degree. So the concept of the treatment for patients with DDH in the first 6 months is Pavlik harness. Again, the Pavlik harness, there's lots of detail that you can find about it in the main lecture about DDH, but quickly here the idea is to prevent adduction and maintain slight abduction of both hips, and also slight flexion from 90 to 100. I'm going to quickly discuss the hip dysplasia between 6 months and 1 year. As I said, there is a full lecture for hip dysplasia in this channel. This is just quickly to describe the condition in early infancy. We discussed previously in the newborns and early infancy. From 6 months to 1 year, as we said, the ortolani test most probably will become negative, because the hip becomes stabilized in the dislocated position and you cannot really reduce it. So what you will depend on is the unequal leg length and the limited abduction. So here's the patient is supine, as you can see here. You flex the hip, flex the knee, and from the foot side you look and you will find difference in the leg length, indicating that in the left side here it's shorter than the right side because it's dislocated. Also, when you abduct, you can see obviously you have less abduction on the left side compared to the right side. Also, the unequal gluteal fold will become more obvious. When the child starts to walk, you will find limping in one side if it's unilateral, or waddling gait if it's bilateral. As we said, there is never pain with untreated DDH until very, very late, maybe in the 4th decade of life. So this was a quick overview of the DDH from 6 months to 1 year. Again, there is a full lecture in my channel about DDH that gives much more detail. In this case now, after 6 months, ultrasound is not as accurate because of the ossific nucleus will not transfer the waves of the ultrasound, so the X-ray is much better. And you can see here, this is the patient. You see in the ossific center here on the left side is in the outside the acetabulum. So you see the acetabulum, here is the right side. You have deep acetabulum, ossific nucleus that is big. The ossific nucleus is the infromedial quadrant of two lines formed at the triradiate and the outer level of the acetabulum. It's in the infromedial part. If you come here in the dislocated, the ossific center is smaller than the normal side. The ossific center is in the outer lateral quadrant of these two lines at the triradiate cartilage and the outer level of the acetabulum. The acetabulum is not as developed. See here, it's well developed. Here it's just very shallow and steep. There is something called Shenton line, which is an imaginary line. You can see here, we call it undisturbed Shenton line from the obturator foramen to the inferior neck. Here, if you draw the obturator and then you go to the inferior neck, it will become disturbed. It's not a continuous line. This is an imaginary line. You can see here it's continuous. Here, if you go, it's not continuous. The inferior neck is far away. How do you treat DDH after 6 months? We do an arthrogram. So here the patient is taken to the operating room. A dye is injected so you can see the acetabulum better and you can see the head, and you do closed reduction and spike cast. Much more details is given in the lecture of the hip dysplasia. So after we finish DDH, let's speak about another very common lower extremity problem that can happen in newborns, which is the clubfoot. So the clubfoot is a congenital deformity of the foot, and it has to be rigid. So it is not a flexible deformity, it is a rigid congenital deformity of the foot. It is one of the most common musculoskeletal disease that affect the newborns, and one of the most common causes for pediatric orthopedic referral. It has roughly the same incidence as dysplasia, 1 in 1,000. It's more common in boys. 50% of the cases are bilateral, and the cases runs in families. So if you have one sibling that's affected, there is a 10% chance that other siblings will be affected. If one sibling and a parent is affected, it becomes about 1 in 4 cases. So what are the types of clubfoot? The most important type that we're going to talk about is the idiopathic clubfoot. There is no other congenital deformities in the child. It's only the clubfoot, and it is the most common type. So the most common type is the idiopathic. That's the type that we're going to describe, and it is a condition that affects the child with no other congenital anomalies. So it will be idiopathic clubfoot. There is something called postural clubfoot, and it is not a real clubfoot because it's not rigid. Basically means that the examiner can correct the foot that looks like a clubfoot to a neutral position, as we're going to see the video in the next slides. The syndromic clubfoot is the clubfoot that happens with as a part of congenital syndrome. Like, for example, the patient with arthrogryposis has a high chance of having clubfoot. Patients with dystrophic dwarfism also may have clubfoot. So in this case, it's not an idiopathic clubfoot, it's syndromic clubfoot. And the neuromuscular clubfoot, it can happen with myelomeningocele, which is basically the spinal bifida, and this can be present at birth or shortly after. And in cases of cerebral palsy, patient may have equinovarus deformity. However, this does not present at the time of birth, and it will present later in life. So these are the 4 types: idiopathic, postural, syndromic, and neuromuscular, that will have a foot that looks like a clubfoot. So we mentioned postural clubfoot. The postural clubfoot is a clubfoot, a patient that has a picture of a clubfoot, equinovarus deformity. However, the examiner can fully correct the foot position. Like this patient here, this foot is highly suspicious of being a clubfoot. However, you see when I hold the foot and push it up, I can fully correct the foot. So this is not a rigid deformity. So this is not an idiopathic clubfoot or a real clubfoot. You can see here this video. So this patient has what seems to be bilateral clubfoot. In the left side, I'm able to pull the foot and fully correct it. If I try to do that on the right side, I can't. So I cannot get it to fully correct the equinus deformity. That's different than the left side here. So you see I can hold and push and get the whole foot corrected fully in all deformities. So this is called postural clubfoot on the left side, and a real clubfoot on the right side. If we see the video again, so if you see the video here, on the left side I can fully correct it. So this is postural clubfoot. On the right side I cannot do the same. I will not be able to correct the equinus. So this is postural clubfoot on the left and the real clubfoot on the right side. So what is the clinical presentation of the idiopathic clubfoot, the one that we're going to speak about? Remember, in this lecture, we're basically focusing on the most common musculoskeletal manifestation in newborns. We discussed the dysplasia. We're now describing the clubfoot. As a reminder, I have a full lecture for the clubfoot. So in this one, we're just going to go quickly over the pathology. If you want more information, you can definitely go to the lecture about the clubfoot. So as we said, it's a rigid deformity, 3 main deformities in the foot, the ankle and foot equinus. So there is an equinus in the ankle and in the foot. There is a hind foot varus, as we're going to see in the next slide, and there is forefoot adduction. Also, another important component of this deformity is the high arch or cavus foot. Some kids will have internal rotation of the leg, and if it's a unilateral case, the size of the foot and the calf may be smaller than the other non-affected side. So the clinical presentation here you can see, so this patient has an equinus. You can see equinus of the ankle, equinus of the foot. You can see this crease here, this is an indication of the cavus foot. There is a high arch of the foot. If you see here, there is varus of the hind foot, and there is forefoot adduction. So equinus, varus, forefoot adduction, the three main, and of course the cavus foot, which is important to understand because that affect the treatment. So equinus, varus, and forefoot adduction. What is the differential diagnosis? It's very important to understand what is metatarsus adductus. Metatarsus adductus has only one component of this, which is forefoot adduction. So the forefoot in relation to the hind foot is pointing inward. And this is a metatarsus adductus. However, there is no heel varus and there is no equinus. So if you see this patient here, if you bisect the ankle, the line will go to the fourth toe. It should go always to the second toe. So this is the normal here. So you bisect the ankle, the heel, I'm sorry, and it will go into the second. If it goes into the third or between the third, if it goes between the third and the fourth or through the third or distal to the fourth, that's of course different degrees of severity of the metatarsus adductus. So the normal is in the second. If it starts to go into the third, that's mild. If it goes between third and fourth, that's moderate, and anything after that is severe metatarsus adductus. Remember, there is no heel varus, there is no equinus, so it is not a full clubfoot deformity. The metatarsus adductus, most cases will improve spontaneously. If it doesn't improve by the age of 6 months, you can apply specific braces or even cast. Now let's go back to the management of the clubfoot. You don't need any x-rays. There is no value of x-rays in the clubfoot, in idiopathic clubfoot. What you need is to do orthopedic referral. In most areas of the world, the treatment will be serial casting by Ponseti. There is another treatment which by physical therapy and stretching. However, in most studies, it gives a very similar result, but not as good as the Ponseti. Also, it requires lots of resources. So the most common treatment is serial casting by the Ponseti technique. As I said, if you want more details, you can go to the lecture of the clubfoot. However, briefly, we go into a serial clubfoot, that is a serial casting that's changed every week till the foot is fully corrected. And then based on the response of the equinus, the patient may require Achilles tenotomy that can be done in the office or in the surgery. After casting, with or without a tenotomy, patient is fitted into abduction foot orthosis that looks like this for about 2 years. The first 2 months it's 22 hours. After that it's about 10 hours a day. The foot is kept externally rotated into that brace. And all this is described in detail in my lecture about clubfoot. So let's speak about now the last thing in this lecture, which is Erb's palsy. Briefly, I'm going to give you just a very brief description of what is the brachial plexus. Again, there is a more detailed lecture about Erb's palsy in my channel. Here, we're going to speak very briefly about the brachial plexus and talk about Erb's palsy as a manifestation in newborn. So the brachial plexus is formed by C5 to T1 roots, which will form 3 trunks, upper, middle, and lower, and these trunks will give divisions. The division will give cords, and the cords will give nerve. What I'd like you to focus here is this part here. It's the upper trunk, which is formed by C5 and 6. The upper trunk here, this area is the area which, if injured, will cause the Erb's palsy. So Erb's palsy is injury to the upper trunk of the brachial plexus, basically means C5 and C6. Types of obstetric brachial plexus palsy, as we said, the Erb's palsy, this is the most common type, and this is the type that we're going to discuss in this lecture and affect the upper trunk as we saw in the previous slide. Pathophysiologically, the neurological affection in Erb's palsy can be either neuropraxia, axonotomesis, or neurotomesis. The neuropraxia is basically means stretching of the nerve, and this usually recover completely with no injury. Axonotomesis means that the axon has been injured, however, the sheath around it is intact. This usually have good recovery, but it's not complete recovery, and there is usually some limitations after the after the recovery is completed. Neotomesis means that the axon and the sheath are both injured, so the axons from inside and the sheath around it is injured, and this carries the worst prognosis. So again, what is Erb's palsy? Erb's palsy, as we said, it's the nerve injury or nerve palsy of the upper trunk, C5 and C6 of the brachial plexus that happens during labor. So Erb's palsy, it's type of obstetric brachial plexus palsy. So it happens during labor, and it's the part that affects the upper trunk. There can be other injuries for the brachial plexus, but as we said here, we're focusing on the most common one, which is Erb's palsy. The risk factor is macrosomia, so kids which are more than 4 kilos. If there is shoulder dystocia, because the obstetrician will pull on the neck, and it can cause the brachial plexus palsy. And of course, assisted labor like using of forceps or vacuum can cause is a risk factor for Erb's palsy. So macrosomia, shoulder dystocia, or assisted labor all are risk factor for Erb's palsy. The clinical presentation for Erb's palsy, the newborn will have what we call the water tip position. So you see here the shoulder is internally rotated, adducted, the elbow is extended and pronated, and the wrist is flexed. And in newborn, especially if you do the Morse reflex, it will give you an asymmetric motor reflex. So you can see this is here one of my patient, newborn. You can see the shoulder is adducted, internally rotated, and elbow is extended, wrist is flexed. So this is a classic the position of Erb's palsy. See here, this is one of my patients. When the kids start to get older, the main thing is shoulder internal rotation. Here's one of my patients in early months of life. So you can see here the shoulder is internally rotated, elbow is extended or semi-extended, and the forearm is pronated. So here I'm doing a video for both sides. You see,
good job. Okay, keep going.
The left side here. However, there is basically no motion of the right
good job.
side.
Okay, keep
it's
going.
internally rotated and it is extended. Again, the video here shows you, so I'm trying to stimulate the kid, I'm trying to
good job.
play,
Okay, keep
and
going.
obviously he's moving the left side, but the right side is not moving. So this is an indication that here this may be, this arm here may have an Erb's palsy. So in Erb's palsy, most cases does not need any imaging studies. However, sometimes there is positive finding in some images, like a chest X-ray. If there is a phrenic nerve affection, like if this is a root affection, which usually have a phrenic nerve, it can you can see elevated diaphragm, you can see clavicle fracture or humerus fracture. And we're going to discuss this in detail in the next few slides. MRI of the cervical spine will, in cases of root affection, will show what's called pseudomeningeal, like you can see here and here. And electrophysiologic studies, if done, will show the nerve regeneration. However, it has very limited clinical uses. Again, in a simple case of Erb's palsy, you don't need any X-rays. These are done in certain conditions. Here we're going to speak about the most common differential diagnosis of Erb's palsy, things that also happens in the newborns and can give you a picture of an Erb's palsy, or and gives you a picture of an arm that is not moving. The more common than Erb's palsy is the clavicle fracture. So you can see here this patient presenting with a clavicle fracture. How to differentiate? The motion of the elbow will be normal, the wrist will be normal. There will be tenderness tenderness over the clavicle, and of course if you put your hand you will feel the deformity, or you can feel the crepitus. The good news is this heals with even with no intervention. When it heals, there will be a big callus of bone and the family will be able to feel it. Usually no treatment is required for clavicle fracture, birth clavicle fracture. We just advise the parents to just keep the arm beside the body, like you can use a safety pin and pin the sleeve to the gown of the patient, or just when you swaddle the patient, keep the arm together with the body. It usually in 1 week it will heal with exuberant amount of callus, and you can see, and then all the motion of the arm will regain. Another case here, so if you put your hand, you will feel the deformity, you will feel tenderness. A few months later, after it healed, it's completely straight, so it will heal in 1 or 2 weeks with exuberant amount of callus, as we saw in the previous, and now after a few months it will become straight. Another important diagnosis for Erb's palsy is a humerus fracture. Birth injury also happens sometimes during birth. Same treatment. The family will be advised to just use a safety pin or tug the arm with the body. This is easily to differentiate from the Erb's palsy. There will be swelling, deformity, tenderness. It heals with excellent amount of callus. It may take longer time than the clavicle, so it may take 3 to 4 weeks to form all this callus. And as we said, it will remodel with time. So here, the birth injuries, you can see the amount of the deformity slightly better at the age of 1 month with a good amount of callus, and by 9 months you can see nearly straight humerus bone. The Erb's palsy, 80% of the patient will show complete recovery. So 80% is just neuropraxia, it will complete recover, and 90% will show complete recovery by 12 months. So most of these patients will improve by themselves. You can, of course, refer to orthopedic. However, if another option is just to wait a few weeks and see if the patient is improving or not. Majority of patients will recover. Even those who don't fully recover will have some partial recovery. So just do wrist of the arm, same thing. The arm is tagged with the body, or you use a safety pin and pin the sleeve to the gown. Just to do some resting for the arm, and then later on gentle range of motion. As we said, 80% of the patients will completely recover. When to refer to orthopedic to the orthopedic surgeon, when to refer Erb's palsy if you don't see recovery by the age of 3 months. Of course, it's very important. We mean by recovery here the function of the biceps. So if the biceps is not flexing, that's an indication for early referral. So by 3 months, if there is no elbow flexion against the gravity, that requires orthopedic referral. If you think that this is a root avulsion, like if there is associated Horner syndrome or phrenic nerve affection, or of course if it's not Erb's palsy, if it's a total palsy, or if it's mainly affecting the hand, what's called Clubfoot palsy, this also needs always referral to orthopedic. Treatment from the pediatrician point of view, just rest for the arm and then start gentle range of motion. You can follow the patient or do orthopedic referral. However, orthopedic referral is a must if the patient by 3 months is not flexing the elbow, or if you think it's root avulsion, or if it's other forms of obstetric brachial plexus palsy like total palsy and Klump's palsy. Thank you. All my videos are for educational purpose only. Please consult your doctor before any decision.